Good afternoon, everyone. It's my pleasure to welcome you to the 2023 Philip R. Nader Legacy of Health Lectureship. My name is Deanna Helsher, and I am the Regional Dean of the UT Health Houston School of Public Health in Austin and the founding director of the Michael and Susan Dell Center for Healthy Living, which has a vision of healthy children in a healthy world and a mission to advance health and healthy living for children and families. So we're very happy to bring you this lectureship today, and we're so excited to have Dr. Osborne with us. So you'll hear her introduction in just a few minutes. But I just wanted to get a few housekeeping things out at the first. So, first of all, I wanted to let you know about our center resources. So, we have regular webinars, bi-monthly newsletters, blogs by and for experts, extensive child health resources, and our Texas Child Health Status reports and toolkits. So, if you'd like to learn more about the center and the resources that we have to share, please click on the QR code there, and we can kind of come back to that later. In addition to these resources, we also have legislative initiative resources through our Texas Research to Policy Collaboration Project. So we create all of these resources and we try and link health researchers to policymakers in the state. So for this webinar today, if you have any questions, please feel free to enter them into the box. So we have some time for questions at the end. And then I also wanted to let you know that this webinar is being recorded. So you will get the link after the webinar is done. So feel free to share that with other people. I know it's going to be a great talk and you're going to want to share it with a lot of different people. And the other thing I wanted to add is if you need chess credits, be sure to email us and we can get those for you. So I'd like to talk now about the Srila and Vibhu Sharma Endowed Fund for Excellence in Community Nutrition, Health, and Wellness. So the Center for Healthy Living houses many endowments that make lectureships like today's possible. So with the Sharma Endowed Fellowship for Excellence in Community Nutrition, Health, and Wellness, students get a stipend and project experience opportunities working with Brighter Bites. So Brighter Bites is a nonprofit that Dr. Sharma found, and it seeks to improve healthy eating in families by providing regular distribution of fresh produce and then education so that people know what to do with that produce. It's really been a successful and fabulous program. It's spread across the US now. And this fellowship is really a great opportunity for students to obtain research. They have a commitment of 2 semesters and they're able to write papers. So almost all of them have gotten a first author paper out of that. So it's really been fantastic for the students and the community that benefits from that. So since 2017, we've had these fellows, and they include Melinda Rushing, Jen Iyer, Brittany Naylor, Fangyu Lee, Nevi Parasarathi, Victoria Kwetua, Iheniwa Odom Nobazi, Heather Jones, and I'm happy to announce our newest 2023-24 Sharma Fellow is Che Zhu. Che is pursuing her doctorate of public health and community health practice at UT Health Houston School of Public Health with a minor in health economics. She earned a master's degree in public health from the University of Western Ontario. We would like to give her welcome and congratulate her. In addition, we'd like to acknowledge the Sharma family for their commitment to public health nutrition and the School of Public Health. So thank you very much. And with that, I'd like to turn it over to Dr. Sharma.
Thank you so much, Dr. Hulsher. Good afternoon. I'm Shrila Sharma. I'm a professor of epidemiology and a member of the Michael and Susan Dell Center for Healthy Living. Before we start this keynote, I'd like to talk about Dr. Nader's legacy, since he's the reason that we're hosting this annual lectureship. First, the Nader Legacy of Health Lectureship is designed to educate and inform academics, providers, public health students, and community members about early life cycle systems and a systems approach to achieving optimal health. Today, we are fortunate to learn and be inspired by Dr. Cynthia Osborne of Vanderbilt University. I've had the pleasure actually of working with Dr. Nader before he passed. Second, this event is intended to stimulate cooperation and collaboration among physicians, patients, families, and communities. The goal is to move together towards an improved health status for both parents and children, a legacy of health for generations to come. We are so thankful for Dr. Nader's leadership and vision. We'd like to thank the Nader Endowment for funding this event and additional staff support provided by the Michael and Susan Dell Foundation. So we also thank the foundation. Next slide. Next slide. All right. So it's now my pleasure to introduce this year's keynote speaker, Dr. Cynthia Osborne. Dr. Osborne joined the faculty at Vanderbilt University's Peabody College in the Department of Leadership, Policy, and Organizations in January of 2022 as a professor of early childhood education and policy. Previously, she was here in Texas. She was faculty at UT Austin's LBJ School of Public Affairs for over 16 years, serving as Associate Dean for Academic Strategies for the last 3.5 years. In 2012, Dr. Osborne founded and directed the Successful Child and Family Research Partnership, a nonpartisan research group that aims to strengthen families and enhance public policy. She's also the founder and executive director of the National Prenatal to 3 Policy Impact Center, an academic research center that translates the science of the developing child into state-level policies with the strongest evidence base of effectiveness. If you haven't Googled Prenatal to 3 Policy Impact Center, do it now. Dr. Osborne's research interests include social policy, poverty and inequality, family and child well-being, and family demography. She has extensive experience leading long-term evaluations of state and national programs with the aim of helping organizations understand what works and how to ensure sustainable implementation of effective policies. And that's really where the rubber meets the road, right, in terms of policy implementation. Dr. Osborne holds a PhD in demography and public affairs from Princeton University, a master's in public policy degree from Harvard University's Kennedy School of Government, and a Master of Arts in Education from Claremont Graduate University. It's my pleasure to hand it over to you, Dr. Osborne, to begin the keynote presentation. Thank you.
Well, thank you so much for the opportunity to be part of this amazing event. And I am really excited to share with you more about what we've been doing at the Prenatal to 3 Policy Impact Center. The whole purpose of our center is to be a resource for states as they look to implement and design the most effective policies that will ensure that all children thrive from the start. And I wanted to step back. I know many of you who are viewing this probably are even greater experts in this field than I am, but I wanted to talk about what it is that guides our work and why we focus so much on the prenatal to 3 period of development. All of our work builds on the science of the developing child that over the last several decades has really made it clear
that the prenatal to age 3 period of development is the most rapid and sensitive period of development that really sets the foundation for lifelong health and well-being. Our brains are the only organ of our body that aren't fully formed when we're born, and it's expecting input from our environment to help us to understand what is safe and what language we'll speak and who our people are. And when we can expose children to safe and stable and stimulating, nurturing environments in those earliest years, we know that that will set them on a trajectory for lifelong health and well-being. But too frequently, there are children, millions of them across this country, that don't have access to these environments early in their life course, and that can really damage the developing brain and body systems, that those effects also last a lifetime. And systematically, it's children of color, it's children from lower socioeconomic statuses that don't have access to these nurturing environments that we know are so essential. And so we wanted to step into that space and not just understand what the conditions are that children need, but we wanted to answer the question of what states could do to create those conditions so that all children thrive from the start. And as an academic, the way that I wanted to enter this space was through research. And we first identified every state level policy that we could think of that might reasonably impact children in their earliest years as well as their parents, and reviewed thousands and thousands of papers and gray material, as well as then hundreds of the most rigorous studies that have been conducted to really understand what the most effective policies are that states can implement. And there's 4 main takeaways from all of the research that we did, and I'll share with you what the policies are that we identified, but I wanted to start with these kind of 4 broad takeaways. So the first is there are things that make a difference. We know what works. For a long time, I have heard people say, well, the problem is too big. We don't know where to begin. And the truth is, we know what works, and we've created a roadmap to try to identify what's effective and where states could begin. And so that was heartening for us to make sure that we weren't going to walk away kind of empty-handed with nothing to share with folks. There are things that work. But importantly, there is not a policy or program out there that is only available to help children. Children don't exist in isolation. They exist within their families. They exist within caregivers. And so our effective policies have to care for the caregivers so that they can do that really important role of caring for their children. And they do it so much better than any organization can. And there's no magic bullet. There is no one policy or program that we can implement and think that our work is done. It takes a system of support that's a combination of broad-based and economic and family supports, as well as targeted interventions to really address the specific needs that children have to create those conditions in which children thrive. And we not only identified what the most effective policies are, we scanned the United States to understand which states are implementing what and how generous they are and so forth. And what we see across this country is a patchwork of benefits and supports for families, so that where a child is born is one of the strongest predictors of the resources that that child will have available to them, both in their earliest years and across their life course if they live in that state. So let me step back again and talk about those conditions. We took all of that science of the developing child and operationalized it into what we call our prenatal to 3 policy goals, and there's 8 of them. And again, these are the conditions that if we could create these conditions in each state, that children could be born and raised in these environments, then we know that they could be on a path for optimal development. And they include making sure that families have access to the resources that they're eligible for, that parents can both work and care for their children, that families have sufficient resources, including food security and housing stability and economic stability, that our babies are born healthy to healthy parents, and that we take into consideration both physical as well as mental health, that parents have the knowledge and skills and understanding of their children's development so that they can engage in those nurturing relationships with their children that we know are so crucial to healthy development in the earliest years. And that when our babies are not with their parents, that they're also in these nurturing environments. And finally, that we can identify any sort of delay that a child is experiencing as early as possible and intervene with the right sort of resources to get them back on track for optimal development. So again, this is the system. And right now, though, our children's kind of goal, the outcomes related to each of these goals vary so much based on both race, ethnicity, but also where the child lives. So right from the start, we have kids who some are ahead of the game and others are already not having access to the resources that they need. I'm going to just provide a few examples. For each of those goals, we identified a number of outcome measures that help to paint a portrait of how kids are doing toward meeting each of those goals, to allow states to try to measure where they may want to focus, what their priorities might need to be. So one of the goals, or one of the outcome measures, is preterm birth. And many of you on this webinar know that preterm births are highly predictive of health and well-being across the earliest years and even into later life course. And currently, about 1 out of every 10 babies is born preterm, but that rate is 50% higher among our Black babies as compared to our white or Hispanic babies. But if you look across the states, and all 50 states plus DC, you can see that babies born in Vermont and New Hampshire and Oregon and Washington have substantially lower rates of preterm births than babies born in Mississippi or Louisiana or Alabama and so forth. And the difference is nearly double from the quote unquote best state, the leading state, to the one with the highest rate of preterm births. And these are things that we know that we can do something about. Another example is poverty, that growing up in poverty, particularly in these earliest years, has pernicious impacts that last across the life course. And nearly 1 in 5 of our little ones under the age of 3 lives in poverty. But that rate varies so much by race and ethnicity and geography. So over a third of our Black babies under age 3 live in poverty, nearly a quarter of our Hispanic babies, and compared to about 11% of our white babies. And again, if you look at the distribution across states, there's 6 to 8% in the kind of Northeast, whereas in the Deep South, it's nearly 30% of babies that are living in poverty. And again, this is a policy choice that we make, and we wanted to investigate what the policies are that can really try to alleviate some of these disparities in outcomes. On our website, we also, for each state, show where every state is. But this kind of graphic is a little too busy for you to be able to take in here on the webinar. But like I said, for each of the goals, we identified a series of outcome measures that help states to gauge how well they're doing on meeting some of these goals versus others. And it helps them to prioritize where they might begin. So with Texas, there is a lot of opportunity for improvement, but there are some areas in which Texas is doing quite well in terms of developmental screening and some nurturing behaviors and so forth. But there are other areas in which there's a lot of room for growth. All right, but we didn't want to stop there. There are a lot of ways that you can find out how babies in your state are doing. And what we wanted to do was to help states figure out how they could do better. And so we created our prenatal to 3 state policy roadmap. And this is our 4th year. We just launched our 4th version of it on October 12th. And I invite you to visit our website. Not only can you pick any state that you're interested in, but there's also a US summary. And then for each of the effective policies and strategies, you can go into a lot of detail about what it is, what the impact is, what the variation looks like across states and so forth. And I'm going to share with you a number of these with a focus on Texas. And like I said, there is a state summary, and this is just kind of a snapshot of where Texas is on our 4 effective roadmap policies and our 8 effective strategies. I'm going to go into greater detail about each of those, but let me just back up for a second to tell you what the difference between a policy and a strategy is. Internally, we created this distinction because we're guided by the research, whether the causal studies kind of tell us that there is a causal link between implementing this policy or program and outcomes. But the research on the policies is pretty clear of what the threshold is that states need to achieve in order to see the outcomes that are associated with that policy change. So a paid family leave program, for instance, needs to be at least 6 weeks in order to see the outcomes. A minimum wage needs to be at least $10 an hour in order to see the associated outcomes. By contrast, for things like strategies, that we don't necessarily have guidance from the literature as to the level of funding that's required by the state or the implementation administration of it in order to get the effective outcomes. For instance, we know that child care subsidies are such an important part of a system of support for families, but the exact subsidy level and so forth, the research isn't clear. But what we have done is gone through and speaking both with experts and those with lived experience, as well as through all the research that we could, is to start to identify the levers that states have available to them to try to make it so that more families can access this. The kind of access to this is more equitable and more effective. So I'm not going to be able to spend time on each of this just for the interest of time today. But again, there's in-depth information on our website, but I wanted to just provide that broad overview. Okay, so again, remember, all of our work builds on the science of the developing child that establishes what the conditions are that children need in order to thrive from the start. And those are each of our goals, and you can see that they're in a row across the top. And then based on our research, we identified the 4 effective policies and 8 effective strategies that help to create those conditions. And this framework, this roadmap, shows you how those policies are aligned with the goals. So when we work with state leaders, we never tell them what they should do. We ask them what their goals are. And if their goals are to promote better birth outcomes, then we can share with them what the research says about what actually is effective at doing that. If their goal is pro-work policies to make it so that families can return to work after having children, or make it so that work will pay for families, then we can also point to the evidence about what affects those policies as well. So I'm going to talk about the 4 policies and then go into the strategies just briefly. So one, like I said, there is a patchwork of benefits and services for families across this country. And right now you can really see that in the adoption of these policies. The 4 policies include expanding Medicaid, a paid family leave program that's at least 6 weeks, a minimum wage that's at least $10 an hour, a state earned income tax credit that's refundable and at least 10% of the federal credit. These are 4 foundational policies that really support families. But there are still 10 states that have not expanded Medicaid. North Carolina will actually implement its expansion on December 1st, so we'll be down to 9. Right now, there are 9 states that have implemented a paid family leave program. There are 5 more that will be coming already that have already enacted the policy, and hopefully more will be coming on soon. There are 29 states that have a minimum wage that's at least $10 an hour, and there's 22 states that have a refundable 10% EITC. And we update this every year, and since last year, 7 states added at least one of these policies, and both South Dakota and Michigan added 2 of these policies. But you can see that there are some states that are doing a lot. There are 9 states that have adopted all 4 of these effective policies and fully implemented them. But there are also 9 states that haven't implemented even one of the effective policies. And unfortunately, Texas, which is where my heart is, and Tennessee, which is where my new, expanding heart and home is, are among the group that still have a long way to go to create this environment in which children can thrive. Now, with Medicaid expansion, many of you are aware that Texas is one of the states that has not yet expanded Medicaid. And it's one of the most effective policies that we have to not only make it so that families have greater access to health care, but it reduces your out-of-pocket expenses on health care to add more money into the household. It reduces poverty, and it is an important policy for focusing on infant and maternal mortality and for child welfare policies. So this is a policy that checks multiple boxes, if you will, but it also is a funding source for so many of the other effective policies that are on the roadmap. But as you can see across the country, there's wide variation in who is eligible for Medicaid based on where you live. And the way that Medicaid policy is written is that without expanding Medicaid, for states that have not expanded Medicaid based on the Affordable Care Act, that no childless adult is eligible for Medicaid, and that states can set the income eligibility threshold for parents and for pregnant people. This is the income eligibility threshold for parents. If a state has expanded Medicaid, then the income eligibility threshold has to be at least 138% of the federal poverty level. Connecticut and DC have expanded it even beyond that. But again, if they haven't expanded Medicaid, then states get to set their rates. And Texas has the lowest income eligibility threshold in the nation, followed by Alabama, so that if a family makes more than 16% of the federal poverty level, that parent is not eligible for Medicaid. And they are way too far away from being able to purchase health insurance on the marketplace, but you have to have at least 100% of the federal poverty level. And that policy choice translates into access to health insurance. So what this shows is that across the 51 states, we include DC in this in all of our analyses, there's huge variation in the proportion of women who have lower levels of income or of childbearing age who have access to health insurance. And so there are some states that you can see in which there's a very small number, fewer than 10% of these women without access to health insurance. And then Texas is a real outlier with nearly 50% of low-income women of childbearing age who do not have health insurance. And this is a huge issue for access to preconception care, being able to access prenatal care very quickly, being able to retain health care after you've had a baby, and interconception care. It matters for all parents, but especially when we're focused on the prenatal period. So moving to paid family leave. Paid family leave is a program that we see expanding across the country. Although there are now 14 states that have enacted a paid family leave program, like I said earlier, 9 have fully implemented it. Both South Dakota Oregon and Rhode Island both implemented their paid family leave programs this year. Colorado will implement its next year. And then Delaware, Maine, Maryland, and Minnesota will all implement their program in 2026. And I think that there's going to be more states coming on very quickly because the number of states that have passed legislation or introduced legislation is large and growing. And it's because it's one of the most effective policies out there for helping children get off to a healthy start. So it not only makes it so that more folks are able to access paid leave or take leave following their child's birth, it's also one of the most pro-work policies that we have. Families or parents are much more likely to return to their pre-birth employment. They're much more likely to be working at the end of 1 year. And that has an impact on both increasing their household resources and reducing poverty, reducing food insecurity, and so forth. And a new study out shows that paid family leave is also associated with a reduction in infant mortality that occurs after the first 28 days of life, which is an important finding. And that's because of all of these other sorts of outcomes, that it's related to better emotional and mental health for parents. It's related to more nurturing engagements and attachment behaviors between parents and children, and more optimal health behaviors like breastfeeding initiation and immunizations and well visits, and all also associated with lower incidences of abuse. So paid family leave is a highly effective program, but how states implement their programs varies so considerably. In Rhode Island, it's only 6 weeks. In most other states, it's 12 weeks. The amount of wages that are replaced varies quite a bit. The maximum dollar amount, who pays for it, whether it's the tax on workers, whether it's shared between workers and employers or employers only, all of this varies so much. We're the only country without a national policy, and so every state is making up their own. And that leads to a wide variation in benefits for families, even though they all have access to a paid family leave program. And so you can see in Oregon, if someone following the birth or adoption or foster placement of their child can take 12 weeks and be reimbursed close to $11,000, this is someone who's earning the national median earnings, that same person would only have 6 weeks and get about $3,600 in Rhode Island. And a state minimum wage policy, what is interesting, like I said, there's 29 states that have fully implemented a minimum wage that's at least $10 an hour. Montana will kind of pass this mark next year, but we don't expect many other states to follow suit quickly, and I'll show you. But a minimum wage policy, often people think, well, no one earns a minimum wage. Well, a lot of people do. More than 2 million workers would have their salaries increased if every state increased their wage to at least $10 an hour. And many of these are parents, and it also suppresses wages at other levels. But it's such an effective policy for not only increasing household resources, it affects birth outcomes, it affects child welfare. And so it's kind of widespread, and it makes so much sense that greater economic security reduces stress and improves outcomes for families. But you can see this variation across the states. In DC, the minimum wage is $17 an hour. In Washington, it's $15.74. But Texas is among the more than a dozen states that are still at $7.25 an hour, which is the federal minimum wage that hasn't been updated since 2009. I could adjust all these for cost of living, but the orders would still be pretty similar. This minimum is still very low and has a big impact on the level of resources in people's households. In the interest of time, I'm not going to spend that much time on earned income tax credit, but again, this is one of the most pro-work policies that we have, and states are really turning to tax credits in addition to earned income tax credits, child tax credits as well, following what we saw at the federal level of these a really important temporary child tax credit that once it was removed, led to a huge increase in child poverty. And so more and more states are looking for tax credits to provide that sort of support for families. This enables them to work, it improves their resources, and it's also linked to better health outcomes for our littlest ones. But if you look across the country, again, just because you have an earned income tax credit doesn't mean it's the same as everyone else's. In DC, it's 70% of the federal tax credit, whereas in Montana, it's only 3% of the federal credit. Next year in Montana, it will move up to 10%. There are some states, those listed here in gray, that it's not refundable. And that makes it so that the lowest income earners don't have access to that credit, and it doesn't have the same level of impact. But there are numerous states that don't have an earned income tax credit. And although it used to be that the excuse was you don't have an EITC because you don't have an income tax, Washington state showed that you can do this. They don't have an income tax, but now they have a working family credit. And there are states that are making it more generous for other populations, for younger populations, those without a social security number, for non-resident fathers, and so forth. So I want to spend just a few minutes talking about our strategies. I mentioned the 4 broad-based economic and family supports that we know help to create those conditions in which children can thrive. But the more targeted strategies really round out the system of support for families. So they include making it so that families have access to what they're actually eligible for by reducing administrative burden. We focus on SNAP because it's the most robust nutrition policy that we have for families, and so many families who are eligible don't access the program, but it applies broadly to a host of different policies and programs. Also, comprehensive screening and connection programs. You may be familiar with things like Family Connects or Healthy Steps. These are programs that universally screen everyone who's born in a hospital or part of a pediatric practice and does a real in-depth understanding of what the family's needs are, and then connects them to those services that will help them meet those families' needs, not just provide them what's available, but what the family actually needs. Our child care subsidies, for any of you who are watching any sort of news, you know that our child care market is struggling. I'll talk a little bit more about our subsidies here in a second. Group prenatal care, which is just like it sounds. During the prenatal period, women of similar gestational age meet as a group and have built kind of both support among each other and learn and how to care for themselves and their babies. And this year, we're really excited to have added community-based doulas to the roadmap as an effective policies. And the focus on community-based here is really essential. That these are trusted members of the community that understand the language and culture and fears and experiences of people that they're trying to serve. And it leads to a host of positive outcomes for both the mom and the baby. Our evidence-based home visiting programs, we focus primarily on parenting outcomes associated with those because that's the most robust area. Early Head Start and early intervention, or in Texas we call it early childhood intervention or Part C services. I'm just going to focus on 3. One is on group prenatal care. And I mentioned what it was, and there's 2 different mechanisms that states have to try to enhance group prenatal care. One is offering an enhanced Medicaid reimbursement for the practice and or funding the programs kind of directly. And Texas is one of 5 states that do both of these things. And group prenatal care has been linked to better access to prenatal care and more adequate prenatal care. It improves reduces that social isolation and improves the mental and social well-being of pregnant women and women in the postpartum period. And it's more likely to see breastfeeding initiation and overall just feel better about their experience during the perinatal period. There's one program model called Centering Pregnancy that has undergone the most rigorous sorts of evaluation. And Texas is what really a leader across the country in offering centering pregnancy here in the state. And again, because of that enhanced reimbursement rate and additional funding, that's one of the reasons why it's able to be more widespread. However, there are implementation challenges about actually how you use that funding, whether it's sufficient and so forth. So we start with the big P policy, but all the little P policy stuff about implementation is so important as well. I also wanted to just note on early intervention services that this year, Texas extended its qualifications for early intervention services to include very low birth weight and making it so that babies right from the start are eligible for these services is so important because we know that low birth weight or preterm that's associated with a host of negative potential negative outcomes. So making it so that families are eligible for these services right away can have such a huge impact on whether the children will experience developmental delays. And our early intervention services have both impacts on the actual health and well-being, but also kind of positive child effect sizes of cognitive outcomes, behavioral outcomes, and so forth. So they're essential services. But even, this is information that aligns with the policy change. So we're hoping that we see a larger increase in the percentage of children who are served by early intervention services here in Texas. And you can see this wide variation. Every one of the strategies looks exactly like this. You have a couple of states that are really outstanding, and then this variation down to states that are doing relatively very little to serve families in these effective ways. And Texas is kind of towards the bottom half here, but hopefully we'll be getting stronger. In the interest of time, I'm going to go through childcare subsidies pretty quickly. I spent a lot of time thinking about childcare because it is a market that is really struggling. But we also know it is so essential to allow families to be able to work. And there are three different ways that states can really make policy changes to have more families be able to access subsidized care and making it affordable as well as higher quality. So one is that they can set their eligibility limit in to at least 85% of the state's median income. That's what the federal government allows. Two is that they can limit the copays to no more than 7% of a family's income. That's out-of-pocket expenses that families are required to pay. And they can set reimbursement rates that actually allow providers to pay teachers what they deserve, to make it so providers can keep their doors open and provide quality care. The federal government uses the 75th percentile as their equal access target. I'll show you that in a second. But there are numerous states now who are moving to a true cost of care approach where they are saying, this is what it actually costs to provide care, and we're going to set our rates accordingly. So just to illustrate where Texas is, it is one of kind of leading states in making it so that the folks who are eligible, there are more people who are eligible to receive subsidies. Now, just because you're eligible doesn't mean that you're going to get a subsidy. There has to be actual spot for you, and Texas does have a wait list, but you can see this wide variation from New Mexico, that's at 166% of their state median income, down to New Jersey, that's just at 42%. So in terms of who's eligible, Texas is doing a really nice job. With regard to affordability, though, limiting the out-of-pocket expenses for families can be a really important way to make it more affordable for families to access care. And again, wide variation. New Jersey, New Mexico have no out-of-pocket child care expenses, no copay, whereas in Ohio or New Hampshire, you can pay over 20 to 25% of a family's income just for a subsidized child care slot. And in Texas, with a family that makes 150% of the federal poverty level would pay about 15% of their income. This slide is really busy, but it actually is my favorite slide because it shows variation across states in a way that no other slide can. And that whole length of the bar is what I refer to as that 75th percentile of the market rate. Every couple of years, states have to survey all their child care providers and ask them what it is they are charging families. And the federal government says that you should create a rate, a reimbursement rate that allows families to be able to access 75% of the market. And so, what that rate looks like across states varies so much. And the market rate is based on what families are able to pay, not necessarily what it costs to provide high quality care. But then you can also see wide variation in how much states contribute to that subsidy and what it is that they require the family to pay. So that first blue is the state's contribution to the reimbursement, and the navy is what states would require the family to pay as a copay. And that teal blue, it shows you when states aren't, that reimbursement rate isn't meeting that 75th percentile. Families would have to pay even more out of pocket if they want that sort of quality care. And Texas is kind of in the middle of the pack with regard to its sister states. So you can see in Louisiana, the state is paying $1,400 a month, whereas in Texas, they're paying about $900 a month. The provider receives about $900 a month, but the family has to pay nearly a third of that. And then the variation across other states, as you can see, exists as well. All right, for the last couple of minutes, I want to show you how all of these policies and strategies that I've been referring to really intersect to provide resources to a family. And we use Lena as our kind of stylized mom. She's a single mother, and she has an infant and a toddler. Her toddler was born at the first, or her infant was born at the first of the year. And she works full-time all year and earns her state's minimum wage. And she sends her children to center-based care that charges at 75th percentile of the market rate. And she took off her 12 weeks of the federal family medical leave that's available. And we want to see how her minimal, like what the minimum level of resources are that Lena has available to her based on where she lives. So I'm going to start in Texas. What would Lena have available to her if she works full-time all year? So if she was working at a minimum wage job, she would earn just over $15,000 a year in wages. But remember, she took off following the birth of her infant. And so, and Texas does not have a paid family leave program. So she loses close to $3,500 in earnings, leaving her just about $11,600 of earnings. And she has to leave her children in childcare. Now, she is lucky that she has a subsidy, because if she didn't have a subsidy, somehow she would have to come up with nearly $18,000 a year to pay for her children in childcare, which would leave her, take all of her earnings and leave her in the hole about $6,000. With that subsidy, she only has to pay just close to $1,000 in out-of-pocket childcare expenses, and so she gets to retain most of her earnings. Now, she does get both SNAP and WIC and the federal Earned Income Tax Credit and Child Tax Credits, which amount to nearly $18,000 in additional resources for Lena and her children. But the state doesn't have any additional resources to provide for her family. And so that's really what she's left with. And that puts Texas towards the bottom in terms of the level of resources that this working family has available to them. This is the second busiest chart that's available. But again, if you go online, you can really spend time, all of their hover text that will tell you everything about each one of these. But it's just meant to illustrate how wide the variation is across this country and what Lena would have available to her based on the state's policy choices. If she lived in DC, she would have over $47,000 in resources. If she lived in the state of Georgia, she'd have just over $20,000 in resources. And I wanted to show a comparison of our neighbor to the west of New Mexico, who's really done so much the last couple of years to invest in early childhood. And their minimum wage is $12 an hour. So Lena has just about almost $25,000 in earnings. They do not, however, have a paid family leave program. They came really close to passing one. I expect that they will probably soon. So she does lose nearly $6,000 in earnings, leaving her just over $19,000. Now, the cost of childcare there is close to $19,000 a year, but she has access to a subsidy, fortunately, and that has no out-of-pocket childcare expenses, and so she gets to keep all of her resources. Again, she gets her federal resources of both SNAP and WIC and the EITC and the other child tax credits. But New Mexico also has their own earned income tax credit as well as child tax credit that gives her additional resources. So here, that Lena has nearly $41,000 in resources if she were to live on the New Mexico side of the border, and only $28,000 in resources if based on Texas's policy choices. So I'm going to stop here so that we can open it up for questions, but it's just really to remind us that state policy choices matter. The earliest years are such an important period for development. We know what it takes in order to help children get off to a healthy start. And I'm really excited to continue to work with Texas and other states so that we can bring more effective policies to children across the country. And I encourage you to visit our website and to reach out to us if there's anything that we can do to support you in the efforts that you have. So now I'll open it up for Q&A. Thank you again.
That was a fantastic presentation. I really enjoyed it, and I think that simulation really brought home a lot of what you're talking about. This reminds me of a talk we had, or where people mention a lot of times in public health where your zip code matters more than your genetic code.
Yes.
Perfect kind of illustration of that.
Absolutely. Yeah. It makes a huge difference. And we think that illustration is, really telling because until you really see it out there, it's hard to put it all together of how these things intersect. And so we're trying to turn that into an interactive tool as well for folks to be able to see what would happen if they change their policies, what it would mean for families' resources.
Yeah, I think that would be really instructive. The other thing I liked about that simulation is the person is working full time. So they do have a full-time job. So it's not like they're collecting benefits without doing a 40-hour-a-week job.
Right. They're doing everything that we typically ask of people to do, which is to work and provide for your children and to put them in, as high quality care as possible. And now it's true in Texas that Lena probably wouldn't be earning $7.25 an hour, depending. We're trying to illustrate what the state's policy choices would guarantee. But even if she were earning $9 an hour or $10 an hour, it still makes it so that the majority of her resources is coming from public benefits. Instead of places like Washington and Oregon and DC, where the minimum wage is substantial, it's close to $15 an hour or more. And there'll be 15 states by 2026 that will have a $15 an hour minimum wage. And the majority of her resources are coming from her earnings. And so there's sometimes this kind of inverse relationship between, in a lot of states that I work with, they really try to push the idea that people should be self-sufficient. but it takes wages to be self-sufficient, not just work. And I think that this really illustrates the importance of that.
So we have a question that's kind of just related to what you just said, is can you please share what the appetite is in Texas legislature to adopt some of these policies around minimum wage?
Yeah, Texas, like Tennessee and other states, are sometimes more resistant to the broad-based economic and family support policies, and more likely to dig in on some of the programs. So we have a really robust home visiting program. We have a robust early intervention program, like I said, and that we could always do more there. But the focus has been more on programs. But you can't program yourself out of poverty. It does take these broader economic supports. This year, Texas did pass a paid family leave program for state employees, which is a really important step, but not sufficient to be able to ensure that everyone has access to time off after having a child join your household. The resistance to Medicaid expansion is something that I'm hoping more and more states will give up. Texas did expand for 12 months postpartum, which is hugely important for women after they've given birth. And we saw North Carolina this year, who was very resistant to Medicaid expansion, finally enact that policy. And there are other southern states, Louisiana, Arkansas, that have. So my hope, financially, it's the right thing to do. Socially, from a health perspective, all the evidence leads in that direction. But I'm not sure that the will is there. I don't know that we would expect higher minimum wages. Texas is one of a couple dozen states that have what we call preemption law, where they have actually intervened to say that cities cannot create their own minimum wage laws, and that is usually a signal that the state will be pretty resistant to that sort of broader change. But never say never. I don't know. Voting matters, so we'll see.
So another question is, it seems like Montana has made a lot of changes just recently, and Montana tends to have a similar legislature compared to Texas. There's similarities, I guess. What has changed or happened there that's kind of pushed? And it seems like they're recent. So what's going on in Montana?
Well, it's really exciting. I mean, Montana is going to both have an earned income tax credit and a minimum wage, both past the threshold this next year. And they've been doing other work on childcare and so forth. And it's been years of advocacy that are now paying off. And the business community in Montana also stepped up to the table and said that these are workforce issues. Childcare, wages, earned income tax credits, these actually help to support workers, and that has helped to shift the narrative. Now, there were some trade-offs. They have an earned income tax credit, but they have tax relief for higher income earners and so forth. What we're looking at is kind of part of the bill, and the minimum wage is increasing because of cost of living increases. So they had set their minimum wage to increase with cost of living several years ago, and that's why it will cross the threshold. But their advocacy has been pretty relentless on these issues, and they have joined forces with the business community stepping in to say that this is something that makes an impact, not just in the kind of social and community lives of folks, but from the economic perspective as well. And each of those voices is really important when you're talking to state legislatures.
Yeah, I love that fact that they were able, that it is a workforce issue and cost of living, because we know inflation's been bad. So
Yeah, yeah. And it's, you know, it's really important that that businesses understand that what their workers are experiencing just to make it to work every day, and that if they can do something to make it easier to find childcare, to make it so that the work that they're doing pays, that they have access to their kind of nutrition benefits and so forth, that they can play a really important role. No, I don't want to start to link childcare with employment the way that we link healthcare with employment. I think that that could be a pretty slippery slope, but it is really it is a workforce issue, and our business community can do so much to kind of help our legislators understand how important it is.
well, I'd love to talk with you some more, but we've run out of time. So I want to thank everyone for being here this afternoon. I want to thank Dr. Osborne again for an excellent, very thought-provoking talk that really shows how we treat the future of Texas and the future of the U.S. By treating our youngest citizens. I also want to remind y'all very quickly that this has been recorded and it'll be archived on our site, so you'll be able to access it again. And then if you need chess credits, feel free to respond to us and we'll get those taken care of. So thanks again, Dr. Osborne. We're so glad to see you back in Texas. And
thank
love
you.
to
I'm
talk to you
glad
some
to be
more.
here.
All right. Goodbye. Have a great afternoon, everyone.
Bye-bye.